you want that, get in touch and I can get it trialed. The good thing about Dictate IT Live is you can put your cursor vital data in any free text field and dictate. You can do it in email, you can do it in a Word document, you can do it in Cerner, in the text box that goes through Cerner. It's software agnostic. That sounds great. Are there any other questions for Dr. Cross?
So welcome, my name is Mark Harbour. I'm a clinical nephrologist from London and I'm part of the Sustainability Network. Thank you very much for joining us. I'm aware we've got quite a lot of people registered to come, so I'll just leave it a second or so. But just to say that this is the first of what we think will hopefully be several webinars as time goes by on sustainability in healthcare. There's obviously a keen interest in this. There's and in that setting, just to say that they're applying for CPD through the Royal College of Physicians. There will be evaluation form that comes back to anyone who's been has attended, and then you can get your CPD from filling that in. So there's no such thing as free lunch, obviously. This is also being recorded, if that's okay. And I'm hoping this will be as interactional as it can be. That will probably mean putting questions into, there'll be time for questions and answers, but as you go along, put questions into the chat box. That would be great. So really just to say that I think everyone's feeling the same way about this whole issue, and the good news is there's an upswell of enthusiasm, energy, and doors suddenly opening. And the UK Kidney Association presidents, past and present, essentially didn't have any hesitation at all in saying that we should set up a sustainable kidney group, excuse me, and are fully supportive of the whole idea of us exploring as much as we can, as fast as we can, so better ways of providing sustainable healthcare, which is essentially just really good healthcare in general. There is a long history of this in UK nephrology, actually, and you'll hear a little bit about this later on, about Green Nephrology, and at least two nephrologists you'll speak to hear from today have been heavily involved in this. But there's clearly a lot more happening now, and we thought we'd start with two kind of scene-setting talks. First of all, with James Dixon, who has a long story to tell in terms of sustainability at Newcastle and has achieved great amounts. We've given him the unenviable task of basically summarising IPCC and the COP26. So James, thank you very much indeed for taking this on.
Thanks, Mark. I'm going to try and share my screen. That will be the first challenge. Can everyone see my slides?
Yep, lovely.
Yeah, great. Okay, I'll start from there. So yes, unenviable task, 10 minutes to cover IPCC and COP26, and acronyms that some people might not be aware of. Very difficult, but I'm going to try my very best. My name's James Dixon. I'm the Associate Director of Sustainability at Newcastle Hospitals, and I've been with the Trust for 11 years now, working as the Sustainability Lead, and I've worked closely over those years with Suren Kanagasundram, who's one of our kidney doctors who's very engaged in this space, who sends his apologies for today, but he was hoping to join us. So I'm going to try my very best to cover a bit of science in these 10 minutes, so bear with me. But then I know that Manraj is going to bring us back from the brink after this and say what we're actually doing about it in the NHS. So this graph here is known as the Keeling curve, and it basically shows the atmospheric concentrations of CO2 over years, all the way back to 800,000 years ago. Now, we've got this evidence from ice cores, but also from a testing station in Hawaii since 1958. And you can see from this graph that it does not get above 300 parts per million at pre-industrial levels. You get lots of natural fluctuations, but it doesn't get higher than that. And the average rate is around 225 parts per million. Now, it's a little bit out of date there. You can get up-to-date readings, but the last one I had from this slide was from June, and in 2019, and it was 414. It's even more than that now, and you can see that it's just rocketed off the chart. So CO2 is the most important global warming gas, and that's what you can see that is having this greenhouse effect and warming the planet and causing extreme climate change. Now, another way of looking at these CO2 emissions in more recent years is the exponential increase of how these CO2 emissions have accumulated year on year. And there's just some, it's actually sourced from Extinction Rebellion, but you can see points on this graph where we've first aware of climate sensitivity. We've actually detected the warming signal. The first IPCC report, bearing in mind we're up to the 6th, and still atmospheric CO2 is on an exponential increase. So awareness is there. Scientists have been talking about it for a long time, but we still pump CO2 into our atmosphere. Now, what this actually means is the world is warming. So this is a nice, easy way of representing how the average global temperatures have increased over the years since industrial levels. And you can see average below medium, much colder, nice blue, and then much hotter in darker red. Now, this is Professor Ed Hawkins, the climate stripes. And another way of showing this here is the bars. You can look this up on this website here. You can even get ties, and my type 2 reusable is a face mask with these stripes on, and it's just a visual representation of how much warmer the world has got over the most recent years. Now, what does this mean? Warmer planet means more extreme weather, and these extreme weather events can take the form of droughts, fires, floods, mudslides, and you can see over the years, even since 1980, the frequency of these events has started to rise exponentially, which is not good for people or planet. Now, the most recent Intergovernmental Panel on Climate Change report in 2021 in August was met with a lot more media coverage than it has done in previous reports. And these are some of the headlines. And you can see the types of, this is a full section of media. This isn't just maybe left of center media. This is across the piece. So really the awareness is there, and words like code red for humanity are really commonplace. So people are really aware of this now. Now, when we talk about, we're currently at 1.2 degrees of average global warming increase since pre-industrial levels. The current trajectories that I'll get onto later are even higher than that. And this is just a visualization of what a 4-degree warmer world might look like. It was from the New Scientist a few years ago, just a conceptual piece. But, you know, just things like this jump out. The Western Antarctica would be unrecognizable. It'll actually be densely populated with cities. You know, how crazy is that? And then you've got whole swathes of the central belt across the world where it's just uninhabitable desert, and areas that were Arctic tundra are now fertile land. And you know, there's lots of bits on here. There's potentially more positive aspects of let's flood the place with solar farms so we can actually power cities. But this was just a thought piece, and it's really scary to know that the habitable places at the minute will be completely uninhabitable. And then moving on to the global equity angle. So you've got the IPCC report, which shows that the atmospheric concentrations of CO2 are increasing. And the people that are responsible for these CO2 emissions are the richest in society. You can see there, source from Oxfam. It's known as the champagne glass, not for obvious reasons. And the shape of it, you can see that the top 10% are responsible for the vast majority of the carbon emissions. So within the Paris Agreement that some of you will have heard of, there was both keeping the Earth within 1.5 degrees safe limit of warming. Bear in mind, we're at 1.2 degrees at the minute. There's also a requirement for global equity principles baked into Paris Agreement. So that is, those that have more should do more. We've benefited in the West and the global North from emitting this carbon dioxide and got a quality of lives. We should be trying our very best to reduce that rate of emissions so that others can actually survive as well. Now, I was asked to touch on COP26, and was it, were the reflections on that very difficult in 10 minutes? And I know Manraj is going to touch on that from a greener NHS point of view. But a great resource is Climate Action Tracker. They're an independent website that basically tracks all of the signs and all of the agreements in these meetings of global leaders and puts them into what is actually on trajectory. And essentially, they've updated this since the COP26, and we're still on track for the actual policies in action of 2.7 degrees of warming. If we manage to meet all of the targets, 2.4, and the pledges and targets, which goes beyond that, 2.1. So we're still over the limit of 1.5 degrees and do not exceed 2 degrees, which was agreed in Paris. And there's some very optimistic scenarios at the end there, but my optimism is decreasing by the day. Just some little notes there on some achievements. I'll not go through them all, but there were some announcements around ending and reversing deforestation, phasing out coal, but some big players did not agree to that. And national declared contributions still add up to 2.4 degrees. So more in the bad COP, certainly how I'm feeling. Now, I wanted to introduce the concept of carbon budget. So we're already talking in big numbers around how we can reduce or mitigate climate breakdown through the carbon emissions that are in the air. This is a term, carbon budget, basically the amount of fossil fuel reserves that we know that are on the planet that have not been exploited yet, or this blue circle here. We have a carbon budget that we know to stay within the safe limits. We have to stay. We have to keep within that carbon budget. And scientists from the Tyndall Centre in the UK have established that we only have, and this was in 2020, less than 500 gigatons of CO2 for a flip of the coin chance of staying within 1.5 degrees of warming. Now that's the budget, but we know that fossil fuel companies are expanding beyond that budget. So that's at risk. But when we talk about the carbon budget, that's the concept. Now you can take carbon budgets down to city level. The Tyndall Centre have done that really, really well. We've actually managed to do that at the organisational level at Newcastle Hospitals. Now, I'll not go into detail, but it's just for energy. It gets very tricky when you're talking about supply chain emissions and things outside of scope. But for energy, you can do it. And essentially what this maps as, you have this budget and the rate of reduction is more important than, say, the zero target that you want to aim for, because this wedge under here is all the carbon that we can emit. It also builds in the global equity principles of having to drop that rate of carbon sooner rather than later. And that's just a little quote there from the Tyndall Centre on our approach here locally. And a wider concept. So we've talked a lot here about climate change. This is Kate Raworth's donut economics principle. If you haven't read her book or seen her TED talk, take one thing away today, please go away and do that, or put it on someone's Christmas list. They will appreciate it. And this concept of the donut is a safe and just space for humanity. So what it brings in is these planetary boundaries. We know environmental boundaries of the planet, the ecological ceiling, as it's called here, that we need to keep so that the planet survives. Well, actually, the planet will always survive. We'll be the ones that die and the planet will carry on. But to keep it safe as an operating threshold for the planet, we can see here where we've breached those boundaries. This is just an infographic from Kate Raworth. And there's also a social foundation. So we can't stay within the means of the planet and not provide for people. If people are falling down, not having good food and good health and security and housing, then you're not providing a just social foundation. So they call this the safe and just space for humanity, surviving within the donut. So we've covered climate change and how we are overshooting that boundary. There's more than atmospheric concentrations of CO2 and climate change. We've got to be living within the space in all of these areas as well. Now that's a heady concept, and I just wanted to put that in there because it's a good way of illustrating that we're too far over this. We need to bring that in, but there's other things like biodiversity loss, change in land over to very unproductive, unbiodiverse space. So, and then I wanted to provide a bit of a segue for Manraj. So we are acting within the NHS. We are acting within organisational boundaries to try our best to try and mitigate the worst of climate breakdown that we've already covered. So we declared a climate emergency. We're the first healthcare organisation in the world in 2019 to do so. And not long after that, Sir Simon Stevens shared a platform with Dame Jackie, our CEO at NHS Confed, and used our words, the climate emergency is a health emergency. Fast forward, they created an expert panel, how soon can the NHS get to net zero? And then they published a Delivering a Net Zero National Health Service report. And this is the first in the world for a health service to commit to that. Not long after that, we produced our own climate emergency strategy and how we were going to achieve that as well. So it is very doom and gloom, but there's still hope if we can act now and we can all come together and collaborate in this space. So I'm still quite excited about the work that we can do with the UK Kidney Association, locally and nationally. And then I've just left that on there for some links for further information and reaching out to us to talk to the team and share our experience. And hopefully I'm still within time, Mark. Thank you.
That's perfect. Thank you very much, and amazing to fit all that in. So thank you very much for summarising that, and also don't want to embarrass you, but the work you've done over the years, that's actually other people, we've been able to kind of step on your shoulders. That's the right expression.
Well, thank you very much.
But it's clearly it's about coming up with ideas and making them happen. Does anyone have any questions about that? And much of this may not be a surprise as it's beginning to dawn on everyone, but the severity of this is pretty major. I don't know if I can see the chat box here, but I mean, I suppose what is a bit different is the fact that there does seem to be somewhat surprising, given that graph. I devised my own graph showing the time that the CO2 and different seminal talks that have happened and announcements, and I suppose what is different this year than last year is that you kind of feel there's been a threshold of appreciation of what's happening, even if we're not acting with anything like the speed we should be, nor indeed our governments around the world. But you do feel, at least somewhat belatedly, we're kind of lifting off the ground. I don't know if that's an impression you get, having been in this business a long time.
Yes, I certainly think so, Mark. When the 2018 IPCC report came out and said we had that 50-50 chance of 1.5 degrees, that was a really dark winter for me. Climate grief, eco anxiety, that kind of thing, rational, response to the impending emergency that we have, worried about my kids, etc. Now, up until then, incremental changes, on the ground, working with engaged people, that I thought that was the right way, but clearly we need transformational change. So we had to step our game up, and certainly I felt there was less climate denial conversations that were taking a lot of energy in this space, mostly fossil fuel backed, like disinformation. So yes, I think we have cause for hope in that regard. I don't have those conversations. You saw the media coverage across the piece on the most recent report, and COP26 has certainly gained a lot of coverage where it was possibly a bit more niche. Health on COP26, I don't want to steal Manraj's thunder because that'll be there, but it was encouraging for me while I was there that it was actually, the World Health Organization had a very prominent space. Health conversations were going on. So yes, I agree with your comments for sure.
And I suppose something I feel very strongly about is that your Keeling curve graph makes the point that essentially waiting for governments to do this is a failed strategy, and that the negligence has been overwhelming, but it hasn't changed the drivers that tend to be less. So really, that curve for me tells me, and from 2018, it's entirely about individuals and institutions. And that's the positive bit. That's where we're at our best. And I think being in a large, lovely organisation, we have the opportunity to, which is as a beautiful introduction to Manraj, who's Sustainable Kidney Cares Committee linked with the Greener NHS programme. And so I'm hoping you could tell us a bit more about that and the impact of COP26 and what the Greener NHS is doing. Thank you very much, James.
Great, thank you. So I'll now have my go at sharing my screen.
That's good.
So hopefully you can all see that. Yep. Brilliant. Great, so thanks so much. It's a real opportunity to be part of your webinar. So as you said, I'm Manraj, I'm one of the Chief Sustainability Officer Clinical Fellows. I'm a urologist by background, so definitely in the right crowd. I've been tasked to sort of give a bit of an oversight of the Green NHS and how we really transition to a sustainable NHS. So I hope I can show this transition by touching on what's been done over the last year since that report that James touched on. But importantly also that so much more still needs to be done and how we go along that trajectory. I will touch on some of the COP26 related issues with regards to the NHS and health, and then importantly on what we can all do as part of the Kidney Association and individuals when we go back to our trusts or day jobs. So why are we all here? And I think James really eloquently put this, climate change is one of the greatest health threats that we will face. We know that air pollution contributes to 1 in 20 deaths in the UK, heat waves are on the rise, and he really nicely demonstrated the wider impacts of climate change on those social or structural determinants of health. And the fact that those that will be most impacted are those that are actually most vulnerable and disadvantaged in our communities, and it will really drive those health inequalities that we saw so starkly during COVID. I'd like to sort of put a bit of a positive slant on it and really say that actually I think it's one of our greatest opportunities, an opportunity really to build on those lessons we learned during COVID, prepare and recover with resilience and sustainability, and really innovate and reimagine how we design and deliver care. And by doing so, I think we can harness those health, environmental, social and financial benefits that come with tackling climate change and adapting to it. I think we're really well placed in the NHS. We're one of the largest employers with 1.4 million staff. Sadly, we are part of the problem as well. We contribute to almost 5% of UK emissions. But again, I think that puts us in a position to be part of that solution if we are all to act collectively. So the Green NHS vision per se came to light sort of last year in October when we committed to being the world's first net zero health service. And that was marked by this landmark report, which you can also add to your reading list if you haven't read it already. It really sets out how we achieve this. It sets out 2 key targets, which are ambitious, but hopefully feasible, on how we get to net zero for the emissions that we control directly. So that's our carbon footprint by 2040. And for those that we can influence, such as our supply chain and travel of patients and staff by 2045. Obviously, this work didn't start last year. It's been ongoing for some time, and it goes back to about 2008 with the Climate Change Act, and that led to the development of the Sustainable Development Unit as the government's response to action on that. A lot of work has gone on since then, and I think many people probably in the audience and definitely in the Sustainable Kidney Committee have been part of a lot of that work, then led to 2019 and the long-term plan, which really sets out an ambition to reduce environmental impacts of the NHS. So there is a big lever there and a push from above to act. Last year saw lots of change. So the Green NHS programme was launched in January to really drive that transition, that sustainability. Nick Watts, the first Chief Sustainability Officer, was appointed, and then that landmark report came out. And where we are now is really that we are in line to support the NHS England and Improvement Board to direct ourselves towards a greener NHS. So the strategy, as James touched on slightly, is fourfold. So firstly, it really looks at the carbon footprint itself. It looks at these clever projections of if we were to do nothing, looks at carbon reductions across the system and what we do to reduce that. So there's interventions, and it lays out a real national roadmap to how we can achieve that. So I'll briefly touch on some of these areas if you're not familiar with them. The carbon footprint of the NHS is shown in this diagram here, and it's divided into these 3 scopes based on the greenhouse gas protocol. So scope 1 in green is direct emissions, such as our anaesthetic gases, our fleet. Scope 2 looks at indirect emissions from generation of purchased energy, mostly electricity. Scope 3 is all of our indirect emissions. So how do we produce, transport our goods and services, and really that big supply chain. The aim to get to net zero really requires all of those scopes plus travel, that forms part of that if we are really to achieve our ambition. This just highlights it in a slightly different way, and the arrows here show you the sort of contribution that these areas give to the carbon footprint. So our supply chain here in blue, or that emissions we control, being 60% direct control of those anesthetic gases, and then travel. And on the right here, you can see that it actually cross-cuts all areas of healthcare. So it's not just in hospital, it's primary care, ambulances, mental health. So we all have a role to play. So how do they go about making or driving change? Is by setting up some work streams. So we've got about 12 work streams in place, looking at those direct and indirect interventions. And what's been achieved since that report is, I'm pleased to say, we are on track. So the NHS has reduced its emissions by 1,260 kilotons of CO2 equivalents. And if that doesn't mean much to you, which for many of us it doesn't, that's enough electricity to power 1.1 million homes. How have we achieved this? Really, it's been achieved through changes in the way we care, how we run buildings, move to reductions in those harmful inhaled anesthetic gases, and really it's required the support and change across the country. We marked our, do shout if you can't hear me anymore, my internet's being a bit temperamental, but I'll persevere until someone stops me. So we marked our 1 year on by reporting to the board, which we've got to do every 6 months, which really makes us accountable and also a mandate to do so. And that's highlighted some of the wins in the first year. We've launched a campaign, a patient and staff engagement campaign, to really get the message out. And that was supported by our now Chief Executive, Amanda Pritchard, who actually did a brilliant video from her visit to Newcastle at that time. And then we've also had the COP26 that really set us off to celebrate our 1 year on landmark. I thought I'd touch on some highlights as part of that, and I'm not going to be very detailed, but just some key areas. So that supply chain, which is 60% of the carbon footprint, and the NHS has 80,000 suppliers in total. And we're really moving towards having a roadmap to get them on board so that we no longer purchase from any supplier that does not align with our net zero ambitions. And this is supported by Priya Bailey, the Director of Procurement, Transformation and Commercial Delivery, who sent a letter out to every single supplier, getting them on board on this journey. At COP, there was some more progress made with in line with our supply chain. So Lord David Pryor really leads with us on this international leadership group and managed to get a lot of the suppliers on board to pledge coming with us on this journey. So GSK, AstraZeneca, Microsoft, and Fiona Godley, editor-in-chief of BMJ, has been amazing, and they had a letter go out to every supplier as part of that. Our estates and facilities, there's a lot more capital investment to move towards renewable energies, and Milton Keynes is a great example for that. They've got over 2,500 solar panels in place. Transport and travel, which accounts to 14% of our carbon footprint. We're looking at low emission, non-emergency fleet. There's also a real push for active travel and innovation around that. And you can see an example from Oxford University where they've used e-bikes as couriers. There's another showcase at COP26 with our launch of the first zero emission ambulance, which has a range of 300 miles. And again, that media coverage that really shows that this is making its way out and that we are managing to frame climate change to some degree as a health emergency. You can see Sajid Javideh also, who visited the ambulance and on board with some of this. Medicines, which makes up 25% of our NHS footprint, 5% from inhalers and anesthetic gases. And I know that there's been a lot of work on anesthetic gases to really reduce the use of desflurane, which is a very potent anesthetic gas, 20 times more than its other alternatives. And a lot of trusts have fully eliminated this. There's been movement with primary care in terms of incentivizing the use of low carbon inhalers. And this is just an example of other areas really coming to the forth with this. So the overprescribing review touches on reduction in carbon emissions with line with pharmacy. None of this is possible without staff and commitment from the whole workforce. And we know now that 9 in 10 NHS staff from a recent YouGov survey are supportive of action against climate change. And it does need everyone to play a part. It needs all 1.4 million staff, and we've got a Green NHS community that I'd urge everybody to join. We've got over 600 members, and it allows a platform for sharing ideas, collaborating and finding out what's going on. So we're not all reinventing the wheel, and really learning to build momentum and move fast on this issue. I think it's really important to work across professional groups, and we've recently launched the Allied Health Professional Hub. If there's any nurses or AHPs in the audience, I think that's a really great resource. There's lots of case studies available, and again at COP26, the staff showcasing of NHS work that's going on, from pharmacists, surgeons, health visitors, who are really changing the way they deliver care and practice with planetary health in mind. And that exhibition's actually on tour and first to hit Newcastle as another first for them. Training is obviously really important, and I think Frances is going to talk in a minute with CSH has really developed some tools on e-learning for health, and we really need to start to have engagements with GMC and Leadership Academy with the Green NHS is underway. I think leadership and governance is key, and within that sphere there's a mandate for all trusts and ICSs to have green plans in place by spring next year, and we've got over 155 doing that now. Leadership, as I mentioned, is part of getting things moving, and we're all leaders in some way, and I think the NHS has really led on this, but it's great to see that we're not the only health system, and 14 other countries have come forward and pledged to be net zero, with 50 other moving towards resilience for those that will probably be more affected. And that's great to see, and hopefully there'll be some WHO partnerships and international work that will come out of this. So what can you do? And I think this is a unique time as a focal point to really drive bolder, faster progress, and try and use this as a way of recovering in a more healthy way with planetary health in mind. Use this opportunity to engage your clinicians, staff, patients, and leaders, and share ideas and collaborate. And hopefully together, we still have work to do. We are making that transition, but there's lots more. So join the communities that are closer to you or your networks, see what the Sustainable Kidney Care Committee is up to, and really get involved. If you're on an organizational level, work towards achieving those green plans, engage your workforce, hold webinars such as this, put it on team agendas and do grand rounds. I think I'll end there, but I will end on this quote, which somebody emailed me after a call last week, and they sort of posed a question of how do we get the green agenda on everybody's agenda? And I think that should be the aim, really. It should be business as usual and part of everything we do. So I'll stop there, and I'll take any questions if there are any.
Manraj, thank you so much for zooming through that, and it is very nice to hear such a lot of positive work that's coming out of this, and as I said before, there's definitely an acceleration here. It is growing exponentially. We have a lot to do. I don't think there's any questions in the chat at the moment, but again, if anyone has any questions, do ask. And I mean, there are a couple of issues really. One is how do we, you're clearly doing lots and lots in terms of comms, but actually how do we mobilize 1.4 million people to then go back to their communities and spread it from there? Because a lot of this is about the kind of accretion of noise and knowledge and so on. And I just wondered if you've got any other ideas about how we do this, how everyone who's on this call goes back to their unit and makes it happen.
I think that's a really, really important point. And I think you're right, it needs a sort of national mandate or levers that can be used, but it definitely needs sort of bottom-up movement. And I think there are a lot of this work is happening, as we've seen, with Newcastle and loads of other trusts who are doing a lot already. And I think they are now regional sustainability teams set up who are having their own comms or display workshops and roadshows that are exhibiting what's happening in your local area. And that may be one way to start, is to link up with groups like that are already doing work within your trust. And if not, then try and make those networks. And I think the greener NHS community just gives that platform for people to share ideas that they're doing on the ground, rather than having to do this sort of, engaging with huge suppliers. But you can individually engage, question your suppliers, start having those conversations. but you're right, there is a lot of doing that needs to happen as well. And hopefully, I think once people start doing and sharing those things, then we can learn and you're not having to reinvent it.
Yeah, I think definitely not reinventing it is, and then it can feel very lonely out there as well if you're starting in a fresh place. And I suppose one of the things that struck me is that there's a sea of networks building up very quickly, so it is possible to get involved. And I'm saying this yesterday, but there isn't a day goes by where a junior doctor or medical student doesn't approach me almost to say, how do we get involved? So there's a real appetite for people to get involved. And I think the other thing is that I mean, I think actually what we should probably do is all go and write to our chief executives and say, what the hell are you doing about this? I don't think yet the direction of travel in most trusts is fast enough, and to our ICS leads and say, we want this to happen. And it takes a bit of an effort to do that, but I think it actually has an impact.
Yeah,
I suppose the other thing, sorry.
I agree. I think, you know, reaching out and saying, you know, who is my sustainability lead? You should have one on every board. Can I see a copy of the green plan? I think everyone is, you know, well within their remit to do that. And at a sort of lower level with medical students or junior doctors, you know, the CSH has a whole wealth of courses and resources that are free to do sustainable QI. And I think it really needs to start to filter in that sort of business as usual. It's part of curriculum, it's part of training, it's part of our everyday thought processes, but it needs to go across, you know, how do we get our nurses on board? How do we make time for them to do that? And all of these things really need to be considered. Yeah.
And I suppose just one other question, hopefully I'm not missing any questions in the chat to know, it's just, you know, there's a conflict. I'm very struck by the fact that, you know, the NHS has been, you know, systemically underfunded in a way for years and years and years. That was pre-COVID, and there's going to be a conflict between asking primary and secondary care to spend more money on doing stuff that might have a lovely 10-year outcome plan or might have a sort of global benefit but not an individual benefit. I just wondered if, again, there's any thoughts about that potential conflict.
Yeah, I think that comes up quite a bit, doesn't it? But I guess my sort of response to that is often that a lot of the things that you would do to reduce carbon or efficiencies around, you know, models of care, if you were to look at the care pathway and try and streamline it, make it more efficient, reduce waste or of time, they've got co-benefits, they will pay back. So I think there's an opportunity here to use recovery from COVID in a really clever and innovative way without additional burden. I think they go hand in hand. I don't think they will be, and I know money will need to go into it, but I think they can be clever, innovative ways to tag them on, because they can achieve the same thing. And you get those sort of environmental, health and financial benefits from streamlining or reducing sort of wasteful resource use.
Yeah, no, I guess we have to break out of somewhat rigid thinking with this. And I suppose one of the things that would definitely be helpful is examples of stuff that people have done that does save money. Quite a lot of this does save money. And then there's an argument of saying, well, we can actually afford to invest this in another project that doesn't save money, but is clearly the right thing to do. So yes, lots of, that always persuades, that always helps anyway. Manraj, thank you very much. That was really, really helpful and very interesting. So our next speaker is this is a recorded talk from Andy Connor, who was our, I think, first Green Fellow, who's going to talk about carbon literacy and a brief history of Green Nephrology. It's a 15-minute talk. He won't be here for questions, but I can make a stab at it at the end. Are you, Sarah, are you able to launch that?
Hello everybody, my name's Andy Connor. I'm one of the nephrologists down here at Derriford Hospital in Plymouth, and back in 2010 I had the good fortune to be the Green Nephrology Fellow. And during that year I undertook quite a few carbon footprinting studies, and Suren has asked me to speak briefly on the subject of carbon literacy and carbon footprinting in renal medicine today. So what does being carbon literate mean? Well, it means having an awareness of the carbon costs and impacts of everyday activities, and the ability and motivation to reduce those emissions on an individual, community, and organizational basis. So for us in renal medicine, what that really means is appreciating the carbon impact of the individual treatments and care pathways that we offer, and also of the infrastructure that we use to deliver these. So why do I think it's important to be carbon literate? Well, I don't think I need to talk to you about that, but what I might explain today is perhaps why carbon footprinting can be helpful. So first of all, carbon footprinting allows us to see the bigger picture, by which I guess I mean that the carbon footprint of services or models of care as a whole allows us to identify the areas and opportunities to focus on, where interventions might be expected to offer the biggest gains. But carbon footprinting and developing an understanding of the carbon cost of the building blocks of these individual services and care pathways can also be helpful. So, for example, knowing the carbon footprint of an individual outpatient appointment, or of a line insertion, or even of a cannula, allows us to then model these different ways of delivering a particular aspect of care. And that in turn helps us to inform our clinical transformation of services to lower carbon models. And then finally, perhaps a less obvious but very valuable role of carbon footprinting is that, very simply, it makes us carbon literate. It allows us to talk about carbon and to do so with some context. And this helps us not only to understand the scale of the problem, but to put it into terms that others can understand. And I think we all think, that as healthcare professionals, it's important that we remember that we are still, unfortunately, at a stage where simply talking about the climate emergency remains a very valuable thing for us to be doing. So what is a carbon footprint? Well, the Carbon Trust reckons that a carbon footprint measures the total greenhouse gas emissions caused both directly and indirectly by a person, organization, event, or product. However, even within that fairly simple definition, there exists quite a lot of opportunity for variability in the way that we assess and develop a carbon footprint. And that's really important when we come to consider carbon footprints that are quoted for us. So some of the sources of variation that we might come across and think about when we look at papers reporting carbon footprints are, for example, the scope of the emissions. So the carbon footprint might include every greenhouse gas specified by the IPCC report, or perhaps it only includes the 6 greenhouse gases described in the Kyoto Protocol. Or then again, maybe it only includes carbon dioxide itself, and each of those approaches might be very valid, but understanding the result requires you to know which approach was taken. Another thing to consider would be the sources of the emissions. So this could be less relevant in healthcare carbon footprinting, but for example, a study might not include those emissions arising from travel. Away from healthcare, the sort of main example of this is studies that might not include emissions that don't stem from fossil fuels directly. So, for example, carbon dioxide emissions from soils. We certainly also need to know the impact of the life cycles of the goods and services lying within the boundaries of the footprint. So we want to know, is the analysis concerned only with the direct emissions attributable to the use of these goods and services, or does it include the indirect emissions that were embodied in their production, for example? And some studies these days particularly will include carbon offsetting, whereas other studies won't. And it's really important when we come in particular to compare carbon footprints that we understand what was included. So at its most basic, the process of carbon footprinting involves a number of steps. First of all, we define the boundaries that the footprint covers. Then we identify which greenhouse gases we're going to include. We think about the most appropriate form of methodology, and I'll come back to that in a second. And when we define the accounting rules, and particularly the time frame to which the carbon footprint relates, then of course we collect the data and analyze the results. And as with all scientific study, it's really important that we consider the degree of uncertainty that will inevitably be present in a carbon footprinting study. So just going back to the methodology of footprinting, there's two main approaches really. And the choice will be influenced by both the aims of the study and the availability of the data. An input-output analysis is also called a top-down approach. And in that way, you have input-output tables of economic accounting data, and they're used to determine economic activity within a sector. And then you then combine that with data relating to the emissions attributable to the sectors. So in this way, the boundary of the study is set by the economic system, and that allows inclusion of both direct and indirect emissions. And this is usually the choice of methodology for larger scale carbon footprints. And it's certainly how the early NHS carbon footprinting studies were undertaken by the SDU. But this approach lacks detail because it assumes homogeneity of financial prices, the outputs, and the carbon emissions. So it's not really suitable when you're trying to assess smaller processes or individual products. And in this situation, we tend to use what's called a life cycle analysis, or an LCA, which is a bottom-up approach of data collection. Now, there is a danger with that approach in that it requires you to set the boundary yourself rather than it being an economic boundary. And so we're determining what's included, and as such, it runs the risk of truncation errors. We don't know necessarily what we're not including, and even if we do, we don't know the scope or scale rather of those emissions because we haven't determined them. So those two approaches can be integrated so that you get the benefits of both. And this preserves essentially the detail and accuracy of the bottom-up approach for more important or dominant processes, whilst the coverage of the less significant processes by the input and output method avoids the truncation errors and fills in the gaps where primary data might be lacking. Now, back when the Green Nephrology program started in 2010, the NHS's Sustainable Development Unit had recently published their first carbon footprint of the NHS. And they used this to inform their carbon reduction strategy, which I'm sure is a sort of document that you'll all remember. And this slide shows how we hoped, back then at least, to influence the carbon footprint of the NHS by 2020. So it's slightly depressing, perhaps, to see that the latest carbon footprint of the NHS in England, which dates looks at emissions from 2019, is still 25 million tons of carbon dioxide equivalents. But that's probably due to changes in methodology as time has gone by, partly the evolution of carbon footprinting in that period. And also because that study used a hybrid model, whereas the earlier studies only used a top-down approach. So perhaps we have made more inroads, and in fact the work by the SDU shows that we have made more inroads than this graph would indicate. Now, back in 2010, the only other health system that had been carbon footprinted was the US system. But since that time, we've actually seen carbon footprints produced for various different health systems, including the Australian, the Austrian, the Canadian, and the Japanese systems. And I think China's also been footprinted. But something we definitely didn't know back in 2010 was what the contribution of renal medicine was to the emissions of the NHS. So we set about trying to work this out. And this is the paper that we published in QGM shortly afterwards. And what we found was that there was a very similar pattern to the distribution of emissions from renal medicine as there were to the NHS as a whole, which is perhaps not too much of a surprise. And when we scaled that up, what we found was that renal medicine was contributing approximately 1% of the overall emissions to the NHS, which when you think about all the things that go into the emissions of the NHS, is quite a considerable amount. Now, you'll remember that one of the reasons for these top-down types of study is to identify those areas in which we might find ways to reduce emissions. And this study showed us quite clearly that dialysis has to be one of those areas, with 65% of the emissions of a typical renal unit coming from dialysis-related activity. So our next piece of work was to try to understand better the impact of dialysis. And we published this paper in Hemodialysis International the following year. And we set out to answer a number of questions. Firstly, what's the actual carbon footprint of hemodialysis? Now, we thought we already knew the answer to this from our previous study, but that was of course determined via a top-down methodology, and calculating it using a bottom-up approach in this study allowed us to do it with greater accuracy and granularity, and also to sort of tire kick the work that we'd done previously. So it was reassuring to find out that the two studies gave us fairly similar results. Secondly, we wanted to know what areas carbon reduction strategies might be most effective within the dialysis process. Thirdly, we wanted to model different approaches to dialysis and look in particular at whether home hemodialysis with its lack of travel is greener than in-center dialysis. And then finally, we were thinking about whether some of the technologies which back then were considered to be a bit newer would fare environmentally. So I won't go into all of those results here, but some of the key points were, well, I'll run through some of the key points. So first of all, these were the different dialysis regimes that we looked at during the study. So we looked at in-center hemodialysis, 4 hours, 3 times a week, and then various different iterations of home hemodialysis, altering the frequency of the treatments and the duration of the treatments. And then we considered what next stage treatments might look like. And what we found was that the carbon footprint of in-center hemodialysis was about 4 tons per year, and that was mainly driven by medical equipment, energy use, and travel. But when you moved over to home hemodialysis and therefore removed travel emissions, a comparable regime of 4 hours, 3 times a week, of course, resulted in slightly lower carbon emissions. But what we found was that home hemodialysis won't remain greener if patients understandably take advantage of the opportunity to dialyze more often and potentially for longer, or a combination of those two. But we did find that a clinically beneficial increase in dialysis time could be achieved with no real rise in carbon emissions. And then finally, we found that next stage dialysis treatment definitely did seem to have a significantly lower carbon impact. And then, of course, we used these carbon footprinting studies to model potential benefits from different strategies and to reduce the impact of dialysis. So we looked at, for example, what would be the impact of recycling with dialysis, within dialysis? What would be the impact of salvaging reject water, which was sort of an academic exercise, partly to demonstrate that it won't necessarily reduce the carbon cost of dialysis, but it remains environmentally the right thing to do. And we looked at another opportunity, which was the retrofitting of heat exchangers to Braun machines. So the field of carbon footprinting in healthcare and renal medicine in particular was something of a blank canvas back in 2011. And 10 years later, that's still, unfortunately, pretty much the case. So looking at that the other way, there's a lot of opportunities there for people and trainees to undertake really quite simple research that's very easy to do, it doesn't require a lot of resources to do the work. But there has been some other work going on, and some of that's been done in within the renal setting. And some of you will be familiar with Professor Agar's work in Australia, where they have also carbon footprinted hemodialysis. They looked more at the hemodialysis unit than the individual process of hemodialysis itself. But again, it was interesting to see that their results were comparable to ours. And these are just a random selection really of papers, but there are a lot of other good examples of work out there looking at carbon footprinting. And all of these bits of work help to refine the methodology of footprinting within healthcare, and also to set the standards, the way we go about doing things that facilitate comparisons. So these are papers from outside of renal medicine, as I say, and they've looked at the emissions associated with, for example, an individual drug. I think that's morphine, and individual processes like, for example, cataract surgery. And they show how you can use footprinting to compare different types of treatment. So that bottom paper there is looking at laparoscopy compared with laparotomy. And they also look at episodes of healthcare. So I talked earlier about the value of knowing what an outpatient admission might cost. Well, there's a study in there that shows what the typical carbon cost of an intensive care admission is. So really, I hope that's been a useful short talk about carbon footprinting. And I guess one thing I would say is that if either any of yourselves or your trainees do want to look into doing some carbon footprinting work, I'd be very happy to try and support them with that. So please do get in touch. Thank you very much.
Thank you very much, Andy. I don't know why I'm saying that because you can't hear me, but I feel obliged to. So I've got a few questions about that, and I suppose the last sentence sort of answered a bit of it, is that if you're feeling a bit overwhelmed about how you do carbon footprinting, then Andy's offer to go and contact him and see what you might do, it sounds like a very, very good place to start. Frances, thank you very much for joining us. So Frances worked closely with Andy. I think is just going to follow on some more points about the Sustainable Development Unit and sustainability in nephrology. And then we'll do questions for both at the end, if that's okay. I think you might be on mute.
Did successfully. Has that not worked?
I haven't got the slides, but we can hear you, which is
You
good.
can hear me. Okay, fine, that's good. And hopefully you will also have slides.
Perfect.
Great. So slightly the wrong way around. I was asked to give a history of green nephrology, and just so it's a bit of a kind of wraparound to what Andy was saying. So my name is Frances Mortimer. I'm the medical director at the Centre for Sustainable Healthcare. And back in 2008-9, we were just starting. So we're an independent charity or NGO working on sustainability in healthcare, and particularly around clinical practice. And we started about the same time as the NHS Sustainable Development Unit. And they were particularly looking at issues around organisational development, sustainability, and buildings, estates and things. So we thought, right, what we'll do is we'll try and understand what's going on in clinical care. And the first big program that we did was sustainable kidney care, or green nephrology as we called it. And this was the first meeting back in 2009 in Oxford. And then Andy was one of two fellows. We managed to get some funding through NHS Kidney Care and create a fellowship that allowed us to do the work that Andy was describing in the video just now, and quite a lot of other things. So it was quite an exciting program. The model which we developed kind of through doing the program, we call our sustainable specialties model. And so this is kind of Andy here, he's the fellow. And the great thing about the fellow is they have time to work on projects and research. But what we quickly found was that it was really, really helpful to create a network of local representatives, and that those people were where we learned a lot of what the possibilities were for sustainable kidney care. And they shared their ideas and their case studies with us. And then Andy's research was helping to sort of shape what needed to happen and to look at the impacts of some of those case studies. And then at the same time, we worked at a national level on the kind of leadership policy kind of side of things. So yeah, at the time we first thing we wanted to do was a survey of kidney units. So we thought, we wrote a survey and we realized it was going to be really long. It was going to take people about 4 hours to complete the survey. So we thought, I know what we'll do. Let's write to all the clinical directors of the renal units around the country and ask them to find somebody who's enthusiastic within their unit to become the local representative. And we had over 80% of the units represented in our network. And they became the resource, as I was saying before. And we created, as well as having events and things where people could speak directly to one another, and we created online networks, and is still now an online network, the Sustainable Kidney Care. If you go to networks.sustainablehealthcare.org.uk, and you can join up there and sort of share your ideas or questions with others there, and find a lot of the resources that we contributed to, and then hopefully now there'll be lots more new ones. And just a sort of flavour of some of the things we did, we ran awards, and that was a good way of getting everybody involved and finding out more about what they were doing. We calculated the impact of some of the case studies cumulatively. So if you added together all of their impacts and worked out that if you scaled them up, so we kind of divided them into infrastructure innovations, which is ones where you have to invest some money and put in, whether it's a big water tank or some other bit of equipment, versus process innovations where you just change the way you do things. And they all create money saving and carbon saving, and some of them save a lot of water as well. And we kind of estimated that if you were to replicate the infrastructure one in 30% of units and the process ones in 60% of units, then you could save £7 million a year and 11,000 tonnes of carbon dioxide equivalents. And actually, I don't think that replication has yet happened, but it still would, I mean, some of the changes have been adopted and spread more widely, but there's still a lot more that we could do. And I think that would be something that we hope to look at early on in the current sustainable kidney care work. And also I would add that these were just the kind of first 20 case studies that we had, and that, there's many other innovations that could be done or are being done. But hit some examples of what they are. Andy has already mentioned in his talk about diverting reject water from water RO units to better uses. Another one, it seems quite old hat now after COVID, but just using telephone clinics in certain follow-up of long-term patients, and showing the savings from reduced travel. And also, importantly, showing that patients actually liked that way of getting care, which a lot of people assume they wouldn't. But there was a big barrier, and there still is to some extent, that the commissioning processes aren't really well worked out, in that services don't get paid enough to cover the staff time. Another important example from Bradford and Airedale, John Stove's work to create a portal that allows really efficient sharing of patient records between primary and secondary care, so that it gives access to specialist advice to GPs, and that can reduce the number of patients that need to go under secondary care, and obviously help to provide useful guidance in a timely fashion. This was one from Cornwall, where they did lots of different changes in one place. They reorganised their sort of transport bookings. They established a sandwich menu so that they asked people what sandwiches they'd like before making them, and that reduced their food waste by 35%. by 30%, from 35 to less than 5%. You probably heard of the example of inviting patients to bring their own blankets to use at dialysis and keeping those in a locker rather than having newly laundered blankets each time. Also changing bicarbonate cartridges to smaller ones that had less packaging. So quite a lot of different things, none of which required any upfront investment. Improving waste segregation, so that waste that doesn't need to be incinerated isn't being incinerated, and waste that can be recycled is recycled. So those are some of the practical examples, case studies, and then Andy has already talked through a lot of the research that that we did. And then just briefly, examples. We did work on with suppliers on specifications for products and questionnaires, sustainability questionnaires for suppliers of renal products, and we fed into commissioning guidelines for peritoneal dialysis, and we were part of quite a few national policy initiatives that were going on, and I think contributed to the prioritisation of AKI as an area of work and prevention, preventing obviously death and further chronic kidney disease from people who've got acute kidney injury. And one of the great champions who again and again sort of supported us and drew us into things that were going on was Donal O'Donoghue, who was the National Clinical Director for Kidney Care at that time. And he also took the message around with him in all the talks that he was giving, and was happy to speak to the BMJ and extrapolate our findings, and talk about how much money and carbon could be saved if that type of approach was applied across all the other specialties, not just in kidney care, because as Andy said, kidney care is just 1% of the carbon footprint and less than 1% of the budget of the NHS. So if you start looking in other areas, then you could presumably find lots more savings. And one of the really important things that Donal also did was to relate sustainability to quality of care, and I think that is actually really, really important, because at the time there was a tendency to look at sustainability as being a sort of a separate issue that was kind of in, like corporate social responsibility. It's kind of a peripheral thing, nice to have, but once you position it as being part of quality, which it really should be, because it's there's no point in creating a high quality service if it's not sustainable. And it's a really important consideration in its own right. So once you position it as part of quality, then I think that moves it much more to the centre of healthcare policy and management and practice. And this has actually led to us going on and developing a framework for integrating sustainability into quality improvement. So you're basically harnessing the quality improvement method and putting it to work to improve sustainability. So we set the goal of SUSQI, sustainable quality improvement, as being trying to maximise the positive outcomes, health outcomes for patients and for populations, while minimising environmental and social and financial costs. And we look to integrate QI across the process, integrate sustainability throughout the process when you're doing a QI project, and then at the end measure the impact on all these different variables that are in this equation. Oops. And when you think about how you can improve sustainable value, then we use these principles of sustainable clinical practice that are listed down here as the secondary drivers to help guide thinking. And just the logic behind them is that we're setting out to try and reduce carbon without adversely impacting health, or if possible we improve health at the same time. And we're looking therefore to either reduce activity or reduce the carbon intensity of healthcare activity. And the ways we might tackle reducing activity include prevention. For example, screening for EGFR. There's good examples of how in the Midlands they're able to reduce, sort of bend the curve of the number of people who were coming through to dialysis by picking up earlier and stabilising them before they reach end stage. Patient empowerment and self-care, so that patients are equipped to look after their condition as best they possibly can, and are also involved in decisions about their care. For example, what kind of mode of kidney replacement therapy they want, or whether they might decide to choose conservative management. And then lean pathways, so that I'm sure you can all think of lots of ways that we could streamline our care and reduce duplications or unnecessary trips. Low carbon alternatives, so that's where, for example, Andy's work of just trying to understand like which modality, which way of giving hemodialysis, at home or in centre, and with what machines would give you the lowest carbon. But we also have got lots more work to do, and we don't actually know how hemodialysis compares to peritoneal dialysis or transplantation, for example. And also lots of other decisions that we make, day to day, as well as those big ones about mode of kidney replacement therapy. And then there's lots we can do on operational resource use, such as, reducing the size of the bicarbonate cartridges, or having bulk delivery, or all sorts of other things. So I guess those are the principles we use. We still find them really, really useful, just to help structure your thinking, and you can see straight away how improving sustainability and improving quality in healthcare can be done together. And if anyone's interested in integrating sustainability into their own QI projects, then do look up the susqi.org website, because there's lots of free resources for how you can do that. And we do also have training courses, if people are interested to learn a bit more and get a bit more help with QI projects or carbon footprinting, or other aspects of sustainable healthcare.
Frances, thank you very much for that. And I'll just plug sustainable healthcare as well. And any of you who kind of feel you want to get going with this, to have a look at that website and contact them if necessary. Frances, I know you've got to rush off to an important meeting, but I wondered if there are any burning questions. There's nothing that's appeared in the chat. If anyone has any thoughts or questions. So do definitely have a look at the website, and I guess the question is how do we get your message and experience to a broader renal audience, apart from getting you to conferences and so on and so forth. I mean, essentially, there's so many aspects of what you've talked about, and things that want to improve in healthcare and nephrology. I just wondered what's your vision of grabbing our collars and getting us all engaged. I mean, we're obviously here on this podcast. This is great. But
yeah, I mean, I guess I go back to the model that I showed with the circles. I think there are lots of different components. I think we need research, but we need people who are just getting on and trying things out, but who are measuring the impact of what the changes they make, and who are sharing that with one another. I'll just put in the chat the link to the network. I mean, that is really a resource that we can make lots of use of if everybody registers on that network and shares what you're doing. I mean, even just knowing that somebody else is trying something out, or answering each other's questions, and definitely posting any resources that you either, whether that's a published paper or something, an audit tool that you've created. And then I think, Mark, you're going to talk a little bit about the committee, I think, aren't you? And the
yes,
work,
just a couple of sentences. That's all. So I suppose a kind of summary of all of this is, what can one do as an individual? Well, there's lots and lots one can do as an individual in one's own life, and needs to go out and do that, and then persuade others. So that's really, really important. And then institutionally, well, that's much of the stuff that Frances and others have been talking about. But the as I said at the beginning, the UK Kidney Association had no hesitation in supporting the idea of setting up a sustainable kidney care committee, which has really just got started, and is driven by a variety of people, including Surin, who's not here, but is the driving force behind that. And after kind of an inaugural meeting, the idea of that group is to promote several themes, including education at all levels, so medics, nurses, technicians, and everyone. Also procurement and procurement pathways, as well as guidelines and research. There's a committee already formed, but there'll be lots and lots of working groups and lots of ways to get involved in that. So I'd encourage you, the website's fairly embryonic at the moment, but I'd encourage you to contact that if you're interested. I think that's really all we want to. I don't know if there's anything else you want to add about the Sustainable Kidney Care Committee or such, but really there is a lot happening. Lots of people who have the same motivations and lots of ways to get involved, it seems to me. And we want you, at this point there, want people to get involved. Anything else to add that you want to add?
Yeah, I can see Robert Peel's asking in the chat, just tell us what to do. I think in terms of your own practice, I think be preventative, empower patients, look for waste, try and be lean in your use of investigations and bringing people in, and similarly try and apply those principles in your service. But the other major thing is to reduce reuse and as much as possible. So I mean, I know that can be difficult if you're talking about a dialyzer or something, but there's a lot of equipment that is used in dialysis, and if you can find any way of streamlining that, you're gonna, sorry, I've got a 4-year-old helping out. Yeah, well, I mean, people will find, even if they just took off a plastic pot off the tray, that because in a dialysis unit they were doing 14,000 treatments a year, that's 14,000 plastic pots that weren't being used each time. And I think those are really good starting points, but then there's lots more to do in collaboration with suppliers and to actually redesign the processes and the equipment to be much greener in the first place.
I'm going to let you go at that point. So Robert's, I guess, is what everyone is feeling, and we will do our best to make it clear how you can get involved in the resources for renal. And again, I've just urged you to go to those 2 sources, but particularly the Centre for Sustainable Healthcare and soon our the Sustainable Kidney Care Committee. But also, actually, as all of us, we find this really difficult. We change our own energy supplier, that's really good. Getting 12 other people to change it is even better. And I think it's about not being embarrassed to make a noise, and not being embarrassed about writing to your chief executive and saying, I want to know what you're doing with your green plan and where you've got to. Is really important. That's there's a degree of urgency with that. And move your bank account. There are tons and tons. We can send around a list actually of sensible things that are easy to do and make a difference because they shift the market and money. So brilliant. Well, I'm going to just draw to a close with that. I want to thank Sarah Crimp, who for organising us, and Surin, who's not here, for getting the speakers organised, and all of you for attending. And there'll be more of these, I'm sure. Thank you very much.
Thanks so much. Bye.